I apologize for the delay. First of all, I would like to thank the organizing committee for giving me this opportunity to talk about the the balloon therapy in obesity. I am Saud Subaie. I am a consultant surgeon in Amiri Hospital. There is nothing to disclose. As an introduction, obesity is a growing global health concern with significant implication on individuals and society. And I think this was covered well by Dr. Matthew and Dr. Carlos. And statistics show that in 2015, there are 58% of women and 68% of men overweight or obese. And the obesity prevalence is non-stoppable, actually. If you compare in 1993, the prevalence was 27% in the US, and 15% in the US, and 27% prevalence in 2015. I will be covering all aspects of intragastric balloons, starting with the definition, history and mechanism, efficacy and safety, patient selection procedure, and what is new in the market of the balloons. Intragastric balloons are simply non-surgical devices designed to aid in weight loss for individuals with obesity. And because it is simple, it becomes so popular for lower BMIs between 30 and 40. And here in Kuwait, the regulation, we can start with 27 and comorbidities up to 30 with comorbidities to 40 BMIs. We can use the gastric balloons also for higher super obese patients as a stage surgery to lower the BMI and make the surgery more convenient. So in the history of balloons, it goes back to 1920 when the observations came on the bazaars, intragastric bazaars. They are naturally forming lesions in the stomach of a natural foreign body. And those bazaars observed to have an effect on weight loss that in 1939, Sir Michael DeBakey have published the first publication of 30 cases of bazaars that showed significant weight loss associated with nausea and vomiting. So after that, the Garam family, a husband and wife, have made their investigation and research in the late 70s that they wanted to do an artificial bazaar that can help to lose weight. So those artificial bazaars, first in the publication, was thought to be inserted with laparotomy and gastrostomies. But with the invention of endoscopies, they published in 1984 about the Garen-Edward gastric bubble. And this is the first intragastric balloon in the clinical practice. And as you see here, it is cylindrical in shape. It's like a Pepsi can inserted and filled with air. So it is with a polyurethral wall. It's a bit a rough wall compared to the recent and new modern intragastric balloons. It's air-filled, okay? And simply with simple air is pumped up in the stomach once it is residing in the gastric fundus. And it is cylindrical in shape. That makes it a sharp, with sharp edges. And it is filled only with a 200 to 220 cc of air. So it makes it a bit not effective because it's of a low volume. It stays for 3 months and then removed endoscopically. So because of it came onto the practice in 1985 in the States, and during the use of the insertions of this kind of a balloon, GE gastric bubble, ulcers was observed in a high rate, which caused perforation, deflation, migration in a high rate with obstruction. So it was the FDA approved this balloon, the gastric Edwards balloon, but it was withdrawn because of the high rate of complications. And actually, the history was quiet until 1987 when an obesity congress in Tarpon Springs, Florida, with 75 international experts with all the fields of gastroenterology, surgery, obesity, nutrition, and behavioral medicine, have gathered up and thought of to develop a consensus and a guideline for the design of a future gastric balloons. So they came up with a Tarpon Spring criteria that they stated that balloon should be effective, it should be to be low carcinogenic and obstructive, with a radio-opaque marker. This is an important thing, that it has to be detected, the place of the balloon should be detected radiologically, and to be adjustable with a various size and volume, composed of a wall that can compensate the harsh environment of the stomach, without edges that are sharp, can accommodate large volume to have an effective weight loss, and to maximize the weight loss and food intake, and filled with fluid, not air. So the first balloon came after the gastric Garen-Edwards balloon was the BIB, bioenteric balloon. And compared to the older balloons, it's spherical, makes it more smooth. It accommodates up to 500 cc in the early stages of the BIBs. It's of a silicone wall, 6 months duration, and it has a radio-opaque marker with a good efficacy and low ulcer rate compared to the other older balloons. And it doesn't migrate, of course. So once the BIB was in the market, the inventions thought came into to increase the duration. So more balloons came with a more duration, up to 1 year. The insertion technique idea came also to be not only endoscopic, to be also peroral, like the O balloons and the ellipse balloon. The content, since the wall is leak resistant, and development and in the balloon wall showed that the leak rate is less, air came again, air-filled balloons came again and was in the market to increase the tolerance rate. Also, the shape was either ellipse, dual-shaped double balloon, or single balloon. The number of balloons inserted to the stomach are either 1, 2, or 3, like the O balloons. And also, the whole material should be more smooth and leak resistant. So what is an ideal balloon? Actually, if we improve the duration, insertion technique, and content with shape, do we improve the safety? Do we improve the weight loss? This is the question that the literature should answer, and I will go through it. So in the market, all those balloons came, and it's like a balloon party, with the different features and characteristics for each balloon. But what is the ideal balloon? We still can't tell which is ideal, actually. And the mechanism is not known yet, but we thought that in the short term, the nausea and vomiting can contribute to the weight loss. The early satiety is because of the volume occupancy of the balloon can reduce the caloric intake and decrease in the gastric emptying with hormonal changes that the balloons studies showed that it increased the fasting ghrelin and the leptin level. And this is a study that showed the effect of intragastric balloon on the gastric emptying and plasma ghrelin level in morbid obese patients, and it showed that the gastric emptying and the ghrelin level is decreased after 6 months from balloon insertion. So in general, the balloons are effective and are safe nowadays, but we have to balance between effectiveness and safety. It is that if we increase the effectiveness of the balloon, we should put in mind that the safety also should be there. And reaching up to higher volumes of balloons is not possible because we will compromise the safety. So it should be tolerable also and should be simple. And the studies have reported, in general, an average of 20 to 30% of excess body weight loss in all the balloons types. And the weight loss mainly happens in the first few months after insertion. The most important factor is patient compliance, but our other factors are contributing, like the balloon type or the duration of placement. This is a study that showed that randomized controlled trial to compare the fluid-filled balloons versus the gas-filled balloon. And it showed that the fluid-filled balloons are superior in weight loss compared to the gas-filled balloons, but it is less tolerable. So once you increase the efficacy, the tolerability will be decreased or the safety. The intragastric balloons, the past, present, and future, was published in 2020 by our colleagues in Jaber, in Annals of Medicine and Surgery, and they compared different kinds of balloons. It's a literature review. And it showed, in average, that the total body weight loss is between 7 and 20 kilos, and the excess weight loss percent is between 6 and 45. This is the literature review of different kinds of balloons. After balloon insertion, the most weight loss occurs in the first 3 months and then slows down, but the weight loss is continuing. And after removing the balloon, there will be a weight regain, but never reaching the weight of the pre-balloon insertion. This is a study comparing control group of a lifestyle modification with lifestyle modification and balloon insertion, and it showed that it is superior to lifestyle modification alone, and after removal, there is a significant weight regain, but not reaching the pre-balloon insertion weight. This is a prospective Saudi study that they studied the efficacy of intragastric balloons, and it showed that at removal and 6 months after removal, the weight is maintained in this first 6 months. And the more the balloon is staying in the stomach, period, like 6 months or more, the weight maintenance will be higher after removal. So if you compare the blue column there, which they did not complete the 6 months of balloon insertion duration, and the red is that they complete the 6 months. The weight loss in the second group is higher, and the maintenance is higher. There is an Italian experience of 2,515 done by Ginko and colleagues studying the bioenteric balloons. And it is not only the weight loss, it is also the comorbidities have improved. And there is a resolution of comorbidities in 44% and improvement of 44.8% of patients. But this is not without complications, and complications there, but they are very low. That makes those balloons are safe. This kind of balloon, bioenteric balloon, is safe. Also, balloons after 6 months balloon can decrease or reduce the liver volume, and this is shown by one study by CT scan. It will be reduced and this can be helpful as a staged surgery. So who put the balloon, or who needs the balloon? Pre-procedure evaluation can be for patients with a primary weight loss procedure, who needs a primary weight loss procedure. Those patients are with a low BMI, with a failed multiple diet attempts, and not eligible for surgery. Or high BMI, preferring less invasive or unfit for surgery. Or motivated patients with clear and realistic expectations. Balloons can be used as a staged weight loss procedure for super obese patients to make the surgery more easy and decrease the liver volume, or for high BMIs with high-risk patients. Also as a bridge surgery before any general surgery, like before hernia, to reduce weight and make the procedure easy and with better outcomes. Patient selection, the age span is from 18 to 65 years old. The patient should be fit for sedation or general anesthesia, should be motivated and compliant patients. Informed consent should be obtained from the patient and discuss all the possible complications. And there are contraindications for the balloon that we should put in mind, like having a previous gastric surgery or coagulation disorder or bleeding lesions in the upper GI tract, pregnancy or desire to have to be pregnant during the treatment, or alcoholism. And relative ones are like previous abdominal surgery, large hiatal hernia more than 5 centimeters, inflammatory bowel disease, chronic use of NSAIDs, and uncontrolled psychiatric disorders. In my clinic, usually pre-placement, I give the patient 1 week of a PPI if he's healthy, and 2 weeks maximum PPI if he or she is a smoker or history of previous ulcer disease. There is a 12 hours liquid diet pre-insertion and 12 hours strict nil peroral. I revise the post-procedure diet program with the patient. And during placement, this is a video. I hope it works there. No. Yeah. The patient, all the patients, I insert the balloon. I keep them undergo under general anesthesia in left lateral position. I do a full gastroscopy, and any lesions seen or ulcers, I terminate the insertion and give the treatment with a biopsy of the stomach. But otherwise, the insertion will be with a fully equipped OT, trained nurse, and monitored vital signs. I inflate the balloon according to the stomach size. Usually the fundus, we study it and we see how much is the balloon fundus ratio, and we decide how much is the volume.
2 more minutes.
Post-placement, it's a day case procedure, 2 hours, and then we discharge the patient with medications, 28 days of gradual diet program, and lifestyle modification. Those are the brochures I give the patient for diet plan and the instructions, and this is the consent containing all the possible complications that can happen. And complication actually really can happen in very low percent. One case report showed that there is a migration of the bioenteric balloon 7 weeks after the date of removal. So 7 weeks after the allocated date of removal, patient did not remove the balloon and obstruction happened, small bowel obstruction. You can see the marker there down. So this is residing in the terminal ileum, and the CT scan have shown also confirmed the findings. This is another case of small bowel obstruction with ellipse balloon by our group. It was managed laparoscopically with enterotomy and balloon extraction and thoracostomy. Gastric perforation and death after the insertion of intragastric balloon. This was a case report published in 2008 and showed that after insertion 48 hours, there was a linear perforation that caused death. New balloons are the reshape and the sleeve balloon. The new balloon, a transpyloric shuttle is a new balloon that will be in the market. It's still in the investigational trials. It is a two-bulb balloon. One larger bulb is in the stomach and the other smaller bulb in the duodenum. It works as a valve in the pylorus that prevent food to go into the duodenum and decrease the gastric emptying time. Okay, this is the last time. That sleeve balloon works as a passage that fills 1/3 of the stomach with a tube that covers the duodenum. And this is a new balloon going for human trials in 2024. And it is promising kind of a balloon because it has malabsorptive function. So in conclusion, the concept of intragastric balloon are stated in the 20th century, making it one of the earliest bariatric procedure. Intragastric balloons are having acceptable efficacy for low BMIs, making it popular because it's less invasive, simple, and safe. Although complications can present, they are rare. Innovations in intragastric balloon are still continuing, focusing on maximum efficacy and safety with minimal invasiveness. Those are my references. Thank you very much.